Good night, everybody. I'm happy to be with you on the slope tonight. I have the intense pleasure to host 3 of my friends on this subject, which will be 1-hour discussion. The idea is for me to ask questions, for them to answer things. I'm not sure they will succeed answering everything, but honestly, they will give it a try. I prepared some nasty questions and nasty slides. We have the opportunity to have your question coming online to this small iPad I have here. So if you have any question, anything that come during our discussion, feel free to ask them. I will try to regroup everything at the end to ask the internet question to this webinar. And I will first ask them to present themselves because it's easier. And I will ask the first guy. So first, of course, we want to say thank you to the two groups that host this webinar. First, PCO. And remember, there will be a huge congress at the end of May in Toulouse. And of course, Newclip, which always support every initiative surrounding osteotomy. For us, they have been very in our back for everything. And once again, thank you, Newclip, for organizing this kind of webinar and to move the discussion forward in osteotomies. So we're going to talk about the boys first and ask them to present themselves. Jörg, first question for you. Little background, where are you coming from? And a little story about you.
Yes, hello everybody. I'm Jörg from Bamberg. This is in north of Bavaria in Germany. And I'm doing orthopedic surgery now since about 20 years. I was born and raised orthopedically from Professor Wolf Strecker, which is an old coryphée of osteotomies in Germany. And he teach me all the skills and the knowledge about the osteotomies. And now I more and more develop myself, and slope has become my most favorite thematic in slopes, my most favorite issue in the last years, and that's making me very happy to be here tonight.
Ragbeer, you're the next one.
Good evening, Mathieu. Good to be with the guys here. My name's Rags, Ragbeer Kaka. I'm from London. I've been working with Mathieu academically, but also with teaching, and I'm based at Guy's and St Thomas's in London and part of the OS Clinic, which is the private group that I'm part of. And I'm a knee surgeon. I specialize in all things around the knee joint, so look after children, adults, and older adults. And a bit like the gentleman here today, I've got a real interest in osteotomy surgery, and particularly around the slope.
Last but not least, Mirko.
Yeah, I'm very happy to be here. So my name is Mirko Herbert, and I'm coming from Munich now. So I started my career in Münster, in the north part of Germany, in the university clinic. And pretty early, I focused on knee surgery and sports traumatology. So I do a lot of ACL and all the ligament reconstruction. My main focus is ligament surgery. But a long time I started with the osteotomies as well. And now I think it's one of the most important part we've learned in the past about bringing osteotomy, bringing the bone and bringing the ligaments together. So therefore it's a great pleasure to be in this amazing group here, and I'm looking forward for the nice discussion.
And the tough questions. So the first question, just to introduce the volume, because I think a lot of discussion will be connected to surgery which might be promoted only by very experienced surgeons. So I want to know for each of you, same thing, Jörg, Rags, Mirko, number of ACL you do a year, number of revision ACL you do a year, number of osteotomy you do a year, and specifically the ACL plus osteotomy, including of course the slope. Jörg?
ACL is about 50, revision about 50, osteotomy is about 250, ACL single stage with osteotomy 0.
Rags.
ACL's close to 100 a year. Revision ACL's probably 30 to 40, something like that. Knee osteotomy, we're doing close to 50 to 60 a year, specifically on coronal, but I do a lot of derotational osteotomies as well. And combining ACL and knee osteotomies, I'd probably about 30 a year, something like this.
Mirko?
Yeah, so ACL, I think is something around 300, 350. Revisions, 80, I think. Osteotomies, normal osteotomies like 50, and ACLs with osteotomies, lobe correction osteotomies, it's like every week 1 to 2, I think now.
Okay, 1 to 2 every week.
Every week, yeah.
That's huge.
So not together, they're like slope osteotomies, but in the last year, I think it was like in single step, it was like 5 ACLs and slopes together in one operation.
I'm jumping on you again. What is your favorite graft for ACL? And why?
Quad.
And why?
The quad.
The quad.
100% the quad, because this is a good graft because the morbidity is very low, and 100% I hate to take out the agonist of the ACL and take out the agonist of the MCL, and both structures are damaged, and I think it's stupid to take them out. So therefore I don't like the hamstrings, I really like the quad.
Rags?
So I'm in direct opposition to that. I use a single semitendinosus graft as my preferred choice, but I've been going more towards quadriceps more recently for my primaries, and certainly for my revision graft, it's the quadricep.
Jörg?
Same to me, like the London style. I like the semi for the first ACLs, and the revision we nearly mostly do quad.
Just a question about, let's say, surgical pressure around you, because sometimes it's defining also the graft. What people in Munich are doing mostly? What is the number one graft in the hospital around you?
I would guess that the hamstring is still the top.
Hamstring? London?
Hamstring, certainly, yeah.
Bamberg? Hamstring.
Hamstring.
Yeah, okay. Another question, tough one. LET. What is the percentage of LET in your practice in primary ACLs? How many patients receive a lateral tenodesis? I'm not talking about the complex cases with the slope and so on and so on. We just focus on the primary, easy ACL. Yeah. Percentage of LET, and based on what do you select the option of doing an LET?
Okay, so it's around 30%.
Okay.
For the primaries, and I'm following an algorithm. So we worked on this algorithm together with Christian Fink in Innsbruck. So we're thinking about the risk factors in a patient, and we analyzed this very similar to the PRS score for the patellar dislocation. And we're following this algorithm, and then we decide if we have a 0.4 and more, then we do the LET, because I want to control myself. I don't want to decide. My operation time is it's pretty hard to get a new case in, and maybe an ACL is enough. Okay. I just want to be very strict with myself, and I decide after this, following this algorithm, I said, okay, this patient needs it. And we make up the guys in Innsbruck, they made a very nice study, and we have great results that maybe we are on the right way.
Ragbeer?
Yeah, I think it's going to be a similar answer across the board. I do LETs in 30% of my patients. So all of my kids that have ACL ruptures have LETs. All of the high-grade pivot shifts, all of my professional athletes will also get it. And the hypermobile patients will get it too. So yeah, 30%.
Jörg, LET?
In primary ACL, I go with less than 30%, much less.
Less than 30?
Less than 30.
Okay.
Let's count it less than 10 or 10. In revision, nearly always, but not in primary.
Okay. I would say the scenario in France specifically is we are moving toward something which is more like 70 to 80% in primary. And I don't like your answer, so I would try to play a little bit against you. But regarding timing, I'm not sure that it's really increasing the timing of my ACL doing a LET. If I do a lateral tenodesis like a Lemaire procedure or inverted Lemaire procedure, whatever it is. The only thing we are focusing on in France is because we do a lot of ACL. I'm doing nearly the same as you, 300 a year. My revision rate cannot be 10% because I don't have the space to do that. I don't have the room to do that. As you said, the timing is short. So we do a lot of lateral tenodesis because we think and we prove, and the team of Santi and Bertrand Sandricoté prove that it's decreasing the number of rupture a lot. So if we were discussing that at the beginning of the discussion, if one of my kids torn his ACL, because I only have girls, I would probably do an LET. No matter what, even without rotatory instability, just to protect the risk of revision. This is one of my points just to discuss.
Yeah, so I think it's interesting to discuss because my problem is that there is a lot of patients you do too much operation on them. So I totally agree. This is a really, really helpful thing, like to do a lemma or anything else. But my wish is, and this is what we are following with our algorithm, to find out who really needs it. And what we could find out now, this is the preliminary results, but we could find that the re-rupture rate is very low in our group, so the group of the Innsbruck guys. And both groups have the same, nearly the same re-rupture rate. So therefore, they did less lemmas with the same result.
Okay.
And at the end, I think this is maybe the even better way, not to put it on everybody. And if you end up with a very similar result, this would be the best way for me. So this is what we wish to find out, but we will see. But this is something very interesting. I think this would be maybe the goal for the future.
Okay. So after this 10 minutes of introduction, we get to the serious problems. I want you, and we start with Jörg, the easiest answer you can provide to this question: why tibial slope is a massive issue in ACL deficient knees?
The story about the slope is the results you see. If you do a lot of osteotomies, and if you see the patients afterwards, and if you see more and more of them, and they all come in your outpatients hours after 6 weeks without any crutches, walking free, and they had 1, 2, 3 revision ACLs before, and they say afterwards, nearly everyone says after 6 weeks, this knee right now feels so stable like it never felt before. Never before. They don't have a revision ACL. They had a tunnel filling and the osteotomy only. And even without the ligament, they feel so stable like they never felt before. And that was convincing me. It started with the Pinchevsky paper. It started with the first results, and they were self-convincing from 1 to 1.
Rags?
Yeah, so if you've got a high slope, your risk of failure, as we discussed for ACL, is really high. And you know that even when you see them in the primary setting. But to try and explain to a patient that actually what you really need is me to do a cut in your bone to get the slope right, to give you a best chance of your ACL working, it's a really difficult discussion to have with a patient, whether that's a primary and even in the revision setting. So that's a real sort of thorny issue with slopes in ACL knees. You know that there's going to be a high risk of sort of still a bit of a Lachman there despite doing a good ACL reconstruction if they've got a high slope. So your results aren't always as good and you can predict that, but having an honest discussion with the patients don't like the idea of having a slope-changing osteotomy.
Jaco, what connects slope to bad ACLs?
So I think the story is fantastic. And I would disagree. In Germany, we are like a country of engineers. Maybe we have been a country of engineers. But at the end, I think it's not that difficult to explain the patient what the slope is going on in your knee. I think it's pretty easy. It takes a little bit of time. But I think the story is completely logical. Starting from the doc, who has a high slope, they corrected since, so it's Slocum, the brother of Slocum, very famous knee surgeon. He was the first guy who did the osteotomy with the dogs, and they're doing fine. So then we have the biomechanics. So I'm a biomechanic guy, so Jens Agneskircher already showed us in 2007 that we have like a loading to the ACL. It is logical, and the clinical results are amazing, and the patient, they feel it. So therefore, for me, I think it's an easy story. Everything fits together, like the biomechanics, the clinical stuff, like the history from the dogs, from the animals, and everything. So therefore, it's logical, and our experience now, it's amazing. So the patient, they feel it, and I feel it. If you do like an examination of a patient with a slope and without, I would say the Lachman of a slope patient is different to the other one.
Okay, interesting. So I will just ask you a side question of this one. Why do you feel a high slope patient failed his ACL in a primary ACL reconstruction? Do you think that this patient, starting with you, will have too much strain and broke the graft, too much strain and elongate the graft, biological issue, not integrate the graft?
Really good question. I don't have really the answer, but maybe I have an idea about that. So I think for me, it's very typical if you have a history of a patient with a slope and revisions, maybe like 3, 4, 5 revisions. Pretty often, they report about after half a year, they feel slowly the knee, it's getting looser and loose. And then once again, they got a new ACL from another doctor. He tell now the other one is stupid. I'm the better doctor.
It was an hamstring. It's
Yeah,
bad.
it wasn't
Let's go to the quad tendon.
You need the quad, and then we solve the problem. You need a big quad, like a 10 millimeter quad, and then we solve the problem. And he will miss, and he will fail. And so therefore, I think there is something, and it makes a lot of sense if you look to the biomechanics, that we have a loading difference, a normal slope or a low slope of around 100 Newton loading to the ACL, and if you go up to 20 degrees of slope, you have 500. And I always tell the patient, so the 10 kilogram and the 50 kilogram, I don't handle, but it's in the gym, so it's quite different. And I think this is something which is very interesting, that when they start putting weight on it and that they get more loading, and I think there is a problem of integration of the graft to the bone and the biological healing and everything. So I see like a problem of biological healing, elongation, and problems like that on the one hand. And on the other hand, maybe it's like it's a higher loading to the ACL when they are more active doing sports, and then maybe it's failing. So this is my idea about that.
Rags, a question for you.
Yeah.
A slightly different one. Do you see in your revision ACL a connection between slope and tunnel issues? I mean, if the patient presents with a high slope, they have often a very enlarged tibial and femoral tunnel.
Yeah, so it goes back to that discussion about biological integration and increased movement when you've got a high slope. So a lot of these patients will, as you say, they'll feel great, okay initially, but they start getting this laxity pretty early on because of the stress going through the ACL. And you get this windscreen wiper effect within the knee joints, where whether you're using a quad, hamstring, where you've got a high slope, the tunnels start to get wider and wider. So when you do your CT scan, what was originally a 8 mil graft, 9 mil graft, you've got a 12 mil hole. So I think you definitely notice that with your revision ACLs, and the patients will tell you, they'll say, felt okay when I first started, but very early on, I started to feel a bit of instability in my knee. So I think it's a combination of too much movement, too much translation, and no good biointegration.
Jörg, another question for you connected to that. Do you think that patients that torn the ACL get the same slope as the, let's say, normal population?
Possibly yes. In many cases, yes. But Andreas Weiler was doing a good examination published in HASM talking about outlier slope values and talking about that we have many people in a healthy population having a slope of 14 degrees and not having any ACL problems. So this brings us later on to this point, which is the point where I jump in a osteotomy in first ACL rupture. I think it is a higher risk, but the really important thing is the really outliers with that very high slope. We're talking about this borderline 12 degrees. I think there you have to be very careful in the first revisions.
Okay. So one of the problem of the slope is measuring the slope. So I will ask you, you can show the images here. You ask me A, B, C, D, which one do you prefer to measure the slope? We discuss other options after that. Which one do you prefer? What is the problems? So this is only post-ACL X-rays. And tell me why some are not valid enough to measure the slope and some are okay to measure the slope. I'll let you start, Ragbeer.
Yeah, so looking at the A and B and even C, the rotation is off. You've got a true lateral on D. Really, in my practice, I don't like any of these, to be honest. I like the long leg lateral down to the ankle.
It's coming.
But if I was to choose out of the four of them, I think the most representative one would be D.
Jörg?
Exactly same.
If you can say something, what is wrong on C?
It's not a rotational problem, but you see the slope, the medial and the lateral slope on both. So this is a little bit not straight, and this gives also a failure in the measurement, I think. And C is the shortest tibial actually. Doing Desure and Bonin, it would be maybe still possible, but it's very short, and you see the lateral and the medial slope divided as a slope dissociation, so it's not correct in my opinion.
So so 2 points. If you dissociate, Mirko, you tell me if you agree on that. If the two condyles are seen differently on the femur, or if the two slopes are not seen exactly superimposed on the lateral view, you reject the X-ray. If you have this patient coming with the X-ray C, okay, would you measure the slope on this one, or ask him to redo the X-ray? This is always a question, because we can, of course, I like the D too, but sometimes the patient just show up with the C, and you can always say, go back to the radiologist. I don't like the C myself, because you see that there is an inclination of the X-ray compared to the femur anyway. But I would say that you can have a fair evaluation of the slope, probably the medial one, and we're going to discuss that after, with the C. Are you agree, or you're not agree with that?
Yeah, so I think it's pretty important if you see like the slope is in a range where you say, okay, this is completely normal, and I wouldn't see any indication for any other operation for that. So I wouldn't do like a new X-ray if it's maybe like 1 or 2 degrees, but it's around 7. I don't care about 7 or 9. So in this case, I would say, okay, that's fine, I can see enough. But if you're on the threshold in the area where you say, oh, maybe this is too much, then I would like to get a really good X-ray. And as we already mentioned, I do it long.
So I don't have the images. So another question for you, Jörg. Do you rely on MRI slopes?
No.
Never.
Never measure. I also don't see the point.
Because most of the literature, initial literature, specifically from the US and Bob Laprade, which is one of the key person around this subject in the US, published a lot of paper with the free sickle methods on MRI. So my question is, would you rely on MRI to measure the slope of your patient if you intend to do an osteotomy? Again, I'm not talking about the MRI you can screen and say the slope looks okay. The patient you intend to do an osteotomy, the revision, for example, ACL, can you rely on MRI? And why not if you can't?
In my opinion, definitely not. Doing the decision for osteotomy. Osteotomy is a real big deal. It's big surgery. And if you have an MRI, the tibia is only on that in very, very little slices and not very long. Let it count about maximum 15 centimeters. And we all know about this tibial bowing that in many patients comes very strong. So then we have a failure, a measurement failure that can be immense. So I never would give the definite indication for osteotomy only relying on an MRI. Never.
Okay, we switch to the next one for Rags. You already answered it. Short or long X-rays. So it's, of course, the same X-rays, left and right, but in 2 different versions. In these specific cases, you can see that the tibia is very straight. So I think the influence of the length of the X-ray is small. But as you said, Jörg, there is a super paper by Wolf Petersen on the subject saying that the longest is the tibia, the highest is the risk, the lowest is the risk of underestimating the slope because of the curvature of the distal metaphysis. So Rags, would you be happy with the X-ray on the right, of course, and are you really only focusing on long X-ray in your practice?
Yeah, so the X-ray on the right, the condyles are nicely superimposed. I think the plateau looks like it's a nice lateral. It's going all the way down to the ankle joint. So for me, this is sufficient. For all of my patients who are having revision surgery, they all get these same X-rays. And just to go back to the point about MRI versus X-ray, the other important thing I like to see is the weight-bearing element of this, because sometimes you can see a bit of an anterior translation of the tibia on the femur. So I think MRI also doesn't really help you with that because it's non-weight bearing, of course. But for me, this is a sufficient X-ray.
Mirko, any comment on that?
Yeah, so I always do a long X-ray even in primary cases. So I think it's pretty important. And the MRI stuff, it's like pretty often when I see in the vision, I saw an MRI, sometimes it's pretty short because the radiologists, they don't have time. They need more cases and more money. Therefore it's like, sometimes it's pretty short. And therefore, sometimes it's absolutely impossible just to get an idea about the slope. And I had 2 cases that I said, oh no, the slope is 100% correct. And then I did the long X-ray, and then I found out it's like 16, 17 degrees. So you can't see it on the MRI. I can see it on the MRI.
Jumping on that, did you take attention to the literature on meniscus slope? Because there is a lot of people promoting the lateral meniscus as the definition of the slope which is detrimental for the ACL. So based on the meniscus slope, which is only accessible using MRI?
Sure. I think there are a lot of questions are open. So even like medial and lateral. So we know that all the literature is about the medial slope, but maybe the lateral is more important. So, but
this is exactly what I mean.
Sorry.
So my next question, let's jump onto this next question. For me, it's a crucial point. Yeah. Do you measure the medial or lateral slope on your X-ray? Because it's exactly what you jump in. The literature is pointing onto the lateral meniscus direction, but it's far easier to measure the medial slope, in my experience, knowing that. I know that Alfred Mansour and Walter Lowe published a paper on AGSM saying that it's easier and more reproducible to measure the lateral one. So it's not my experience, but once again, the guy from Texas seems to have more experience on the lateral slope measurement, on long X-ray, same thing. And and sometimes you have a differential of 5 degrees if you do CT scan. So medial or lateral, and why? sorry for this.
No, fine. So on the one hand, it's pretty interesting. So if you have a difference, so where there are some papers out that you have like a rotational problem, like an internal rotational problem, is there the difference between medial and lateral? Maybe we have to correct one or the other. A lot of questions open. So for me, it's like I check both. I always check both, and if I try to correct them, and if I find a threshold where I want to start osteotomy or not, I go to the middle of both. So this is if they are different. So maybe one is 15, the other is 17 or something like that. So maybe this would be like the 16 for me, just for my opinion or maybe my decision to do an osteotomy or not. But I have no conclusion if medial or lateral it's more important.
Nobody want to jump onto the lateral? Jörg, maybe? Medial too, or?
What we measure most times is the medial aspect because it's more easily seen. It's more sclerosis down there, it's more straight. The lateral one is more tiny. And
sometimes it's convex,
exactly.
Pretty far convex. It's pretty hard
most times it's convex, so it's more difficult to measure, and you've got more failure in the measuring of the lateral aspect. To have a slope dissociation between medial and lateral, which appears is if it's a straight lateral view, it's quite seldom, but it happens that you have slope dissociation. But most times what we measure is the medial side.
Rags, next is for you. Mechanical access of the tibia. Yeah. There is plenty of options. Some people, you can show maybe the picture. Some people will measure the anterior cortex. Some people will measure the posterior cortex. Some people will try to figure the center of the diaphysis and the 2 metaphysis with the circle method, for example. Which one would you select? The blue, the orange, or the green? Looking at that, you can see that the difference is plus or minus 4 degrees with the same tibia.
Yeah. So in my practice, we prefer to do the circle technique. So I draw 2 circles at fixed distances, and you can then define your posterior tibial slope. So it's probably closest to the orange line, I would say. And as you can see, there's a significant difference, right? So if you're sitting on the fence between a 10-degree slope and a 14-degree slope, it will completely change your management. So I think based on a lot of the literature that I've read, the circle technique is quite an accurate way of checking it.
Mirko?
Yeah, I totally agree. So for me, it's just for my expression about especially if you have a bowing, so then the circle technique makes a lot of sense for me.
So you circle the distal metaphysis, the proximal metaphysis, the best shape you can do, and you connect the two centers, and you define your mechanical axis to be that.
Yeah, so in the proximal part, I'm on the top tip. Usually I perform the circle, and then pretty far down, pretty far distally, I do the other circle and then connect it in the middle.
Jörg?
The circle.
The proximal circle a little bit lower than the top tip, and with the distal circle you can get highly different results. especially in a high tibial boning. This picture has no high tibial bowing, so there the orange line comes straight, but you have some outliers where you put the distal circle down there, and it's even wandering out of the bone. Yeah. You have that very hard bowing, and there is a good question: how far do we go? Because the first paper that gives us the borderline of 12 degrees from Binchevsky has not been taking that very long pictures. So if we come right now with these very long pictures, we have higher slope values, and so we probably need to put the borderline a little bit more high.
Ragbeer, do you use CT scan? So it's the exact same patient with the 3D morphing of the tibia, and you can see that the slope is 14 now. So we go for 70 to 76 with the exact same patient, 3D modeling, and then 3 different landmarks taking on X-ray. So probably the reality is something like is close to this one, close. But it's the major slope measured on a CT scan with 3D models.
So the only time I would consider doing a CT scan is if I'm doing a multiplanar correction. So if you've got a varus valgus as well as a slope issue, then I get CT scans. The sort of healthcare setting that I work in, resources, you've got to think about getting CT scans for everybody's not always available, and X-ray is a quick and easy thing to do. So I'd love to have a CT scan, I think it's useful, but only in multiplanar deformities.
So we just went through the first half hour, and we have many questions. I'm sorry, we'll try to answer everything all along, because some people are starting to talk about treatment. We are going into that. But we have a specific question for you, Mirko, one of your fans, saying, how do you discuss with the patient about the osteotomy? You can leave this one for after. Are you performing long X-ray on every single primary cases?
If I do this?
Are you doing X-rays for every single ACL patient?
Yeah. Yes, I do.
I don't.
I don't.
You do.
I try to, but it's in a big hospital setting, not possible.
I can tell you why.
Go ahead.
No, my problem was that I was sitting like 3 years ago when we started with the slope correction, and I had my own patient, and he had a revision. And then I checked, I just seen on the MRI that there's obviously a slope problem. And then I checked for the slope, I did the X-ray, and then he came back and said, "Whoa, yeah, we have a problem." So, but we didn't know. When I did the operation, I didn't know something about the slope, and you have a slope around 18 degrees, and yeah, there's a reason why you failed. But then I was thinking about, what will I do in 3 years? Then the patient is coming back, and I can't tell him I didn't know that the slope is a problem. You have a slope problem. I can explain you. He said, well, why didn't you check it? Why didn't you correct it in the first step? And this is the big problem for me. And therefore, then this was the reason why I started to check for the slope with the primaries, and then I can discuss with them. Very few of them get a slope correction, very, very little.
Subsequent question, because otherwise we're going to forget this one. What do you think is the percentage of failure in a primary ACL patient with a 15-degree slope? Internet. Thank you for this internet question. I really like it. So you have a 15 because how many? We were discussing about doing too much for patient like LET. How many patients will really benefit this X-ray?
This X-ray. I think they
all of them maybe.
Yeah, all of them.
So how many of them will
because
have a new ACL rupture with a 15-degree slope? I think we don't know the answer.
We don't know. I don't have holes in my hand, but I don't know. But I think I would definitely expect, and I think we have some evidence that there should be a higher risk for this patient to get it.
I remember a discussion with Bertrand Sandricoté. He was saying, like, if you measure the slope in every single ACL revision, all of them are above 12 or 15. So it's not a question of how many get a normal slope, because all of them get a normal slope. It's not always 100%, but when you X-ray every single revision ACL, this slope value is huge. This is my own experience. I do that for every single revision, and the number of patients with a 12 to 15, which we can be questionable in terms of indication, we're going to get into that in a few seconds, this number is high. It's like 9 on 10.
But on the other side, I can give you my experience because I check every primary. And I say it's not like everybody has like a abnormal slope. there are a lot of patients, they have a normal slope, and I'm totally fine with the primary ACL reconstruction, but most of the time we discussed about LET, but when I discussed with them, you have like a slope of 13 degrees, for example, then I tell him, you are playing football, you are 18 years old, and you have a slope of 13. This is pretty important for my decision-making process, what I do with you. And then we can discuss about the bone, I tell him, but then I said, mainly I do like an ACL, but not without an LET. So this is most of the time is my reaction on top of that. And at the end, I think it's very helpful. You talk to the patient, you're explaining his risk. He can decide if you want to go back to football, if you want to do anything. And when he gets a re-rupture, he cannot blame you because you didn't tell him. So you put him together and you're working together and you make a decision-making process together. And this is very helpful, I think.
Okay. So let's get into business. Cases. First one, for you, Jörg, we have a 33-year-old patient. Sports, running and cycling. ACL 6 years ago. No new trauma, but have been unstable for 2 years. You got a ramp. You got the lateral root tear. His slope measure on long X-ray is 78.1 on the medial one and 84 on the lateral one. Let's say. What would you recommend? What would you be your question? You can ask me if I have other things. Maybe I have them. Message: 33 years old, no big sports, easy, not doing sports every day, not a professional. 6 years down the road, first ACL, no new trauma, unstable, 2 meniscus, completely dead.
So what we see, in my opinion, the lateral view is not long enough. I would like it a little bit more longer.
Okay.
In my opinion, in the lateral view, that you see the femur condyles are in a good shape, but the tibial head is not actually. Okay. And this is a little bit about the internal rotation, internal articular rotation. We do not know much about that. We have now new values defined by Jörg Harrer, telling about rotation could be 4 degrees, but could be much more. And you see, it's good in the femur, but it's not good in the tibia. So he has an internal rotational problem. I see the tibial drill hole is quite wide. I would say at least 12 millimeters. The patient is, in my opinion, as a 50-year-old guy, quite young. Yes, he's 33.
Very young.
Very young.
Very young.
He has a ramp. He has a root here. So he's facing some kind of surgery, I think. Yeah. In a Middle European country, yes. So even if he has now stop-and-go sports, he would go in a surgery, and probably you would not suture a ramp or a root tear without repairing the ACL. I think we have a consensus in that.
True.
And then it's an easy job, because the ACL needs a tunnel filling before, at least in my hands. Consensus?
Most of mine are single-stage revisions.
Single stage?
Yeah.
Single stage?
Yeah.
So
on this one, I'll probably do single stage.
Yeah.
With
even with that
tibial,
the tibial tunnel is quite ventral, and look the ventral aspect. Okay. I would prefer a tunnel filling, and then it's an easy catch, because then I tell the patient you need the tunnel filling anyway. I enlarge the surgery about 40 minutes for an osteotomy. The full weight bearing is going to be reached 3 weeks afterwards. You're not going to lose anything, and we give you a better result. And then I would go for the slope with that patient also. Depending on the new lateral X-ray. Yeah.
Let's imagine that you have 78 rags.
So we know that
78 on long X-ray, 2 meniscus done, 1 to be operated to be stable again.
So we know the failure for ACL reconstructions is multimodal, and looking at that tibial tunnel is too shallow for me. You can just make out the femoral tunnel as well. I suspect the positioning won't be ideal for that either. It looks a little bit, once again, shallow. A CT scan will be useful in this patient to work out all the other factors. And I completely agree with you, the long leg is important, but let's assume it's a 12-degree slope. I think you have to have a discussion with the patient. For me, this patient doesn't do many cutting sports. They've got other things going on. They've got a ramp. They've got a lateral root tear. These will be obviously part of the instability picture. They've not had a tenodesis. It's a good discussion to have. if it was my knee, I'd be looking at getting a slope correction if I was this kind of patient. But really, most of my patients would probably err on having a revision ACL as a single stage with an LET. That's the reality of what I see.
Mirko?
Yeah, so I would go the same. I totally agree. So I think in this case, with the age, with the sports and everything, I wouldn't go for a slope correction with 12 degrees.
You will not?
No,
At
no,
12.
no.
I will not.
I wouldn't do that, but I would put an LET on top of that, and the tunnel would be I would do a CT scan. Just want to see the femoral tunnel is pretty far anterior and and the tibial as well. So therefore, but could be single stage, but depending on the CT scan.
We have a good question from the internet that asks the question about this 12-degree slope. Will the impact of this 12 thing will be different in the auto versus allograft? We don't like allograft in Germany, I know that. But
we don't get it and we don't like it. But I wouldn't expect like a benefit if you have an allograft.
The scenario is worse.
Even worse. So I think
so would you go more for a slope change if, for a reason, the only option is an allograft in this specific scenario? It will not change much for me, but I think it's a good question. And if we argue that the main problem with slope is the healing rate, allograft make it worse.
Yeah. So. But anyway, I think we have so many options. So even in Germany, we don't get an allograft. It's nearly impossible to get a good one, but always you find something else. So therefore, I wouldn't go for an allograft in this case anyway.
I will not ask you, Jörg, on this one because I know your answer already, so I will ask Rags. This one is this is the one we discussed a few minutes ago about the lateral short versus long. So he's 21, he's a pro football player, ACL 3 years ago, have a new trauma during the game. He have the new ramp that was repaired 3 years ago. The graft is dead, and he's more pivoting than drawing. So, I mean, the main issue is rotating instability. He had a 74.3 degree slope. He is a professional athlete.
So this is a really interesting conversation because we don't have data for professional athletes and slope correction. Yet. I'm sure you'll publish on it soon.
No, but there is some big paper coming from Texas on that, on NFL players.
Yeah. So I think for me, this patient is a professional athlete. His primary aim is to get to the end of his career in a quicker period possible to recover and start doing his sports again. I think we know that he's got a high slope. You could talk to him about slope correction, but there's no way this patient would want that. They'd want to get back on the field as quickly as possible. So for me, in my practice, I would revise his ACL, I would give him an LET, I'd fix his ramp, I would do a autograft rather than an allograft, and I think I wouldn't do a slope change for this patient.
Mirko?
I disagree. So I don't have like a big experience about professional sport, but I did like 3 years ago, I did a professional football player, soccer player in Germany, and he had like a revision ACL after MCL ACL reconstruction. He has a bucket handle tear. So I did a one-step ACL revision, I did the bucket handle tear repair and the slope correction in one operation. 3 weeks later, he was calling me from his rehab clinic in Hamburg, and he told me that they don't trust him that he got an ACL. He had just a muscle injury, and they don't trust that he had like an ACL reconstruction because he's good like hell. Yeah. So therefore, and this is our experience, that slope correction is not a big thing. They are afraid of that, but they're doing so fine. And I asked all my patients for the revision, and most of them, they told me every slope correction is less than all ACL reconstruction they got before because they feel so good.
Did you reconstruct the ACL at the same time?
Yes. Single step ACL, slope, and bucket handle tear repair.
It's amazing to imagine that they have a different rehab than a revision ACL, just adding a plate and a correction of the slope, you know. But I agree with you, sometimes they just said, it's not the same surgery I had. Maybe because you're very good.
No. There's
Jörg, I will
like
not
this.
leave you this one because the time flies. I give you this one that I really like. He is a 26 years old boy, ski instructor. Very important. I love skiing. We all love skiing, specifically rugby. And so left knee is okay, but have an ACL 5 years ago and 2 sequential revision. Is now stable. right knee had the first ACL 2 years ago and have a recent failure during skiing activity. ACL is dead and have a bilateral root tear. So this is what he have in his both knees. He had a 15-degree slope bilaterally. Let's say so if it's 75 ppta. We are only massive, as you can see, a drawer of the tibia on the right. So it's a D, sorry for the French, but it's D is right. So no big question regarding would you do a slope or not on this one, I guess. The question he asked me is, why not doing the left one? Because I'm probably cursed and will have the same problem on the other knee. So he asked me to do bilateral. I said no. But this is a good question because the patient I operate now with slope osteotomy, they all ask me what will happen to my other knee, which is always very symmetric. So question for you, would you do a bilateral for this young guy?
In my opinion also, they are very symmetric. It's not like a torsional deformity that in sometimes appears only on one side, but slope appears quite symmetrically. If you see it, that the G means the left side picture, right? There we see a severe tunnel situation, very steep down going tunnels. The slope is 15 degrees also.
Yeah.
The left side is hard to operate, I think, because something's wrong with the tuberosity there. Maybe it was a patella tendon or something, what they did there.
BTB.
Yeah, and the very steep down-going tunnels, you have to imagine if you want to stay below your tunnels, which we in the infratuberosity technique, or we always want to, how deep you have to come. And the problems he has right now is on the right side. Acute problems right side.
Yeah.
I would first go for right side.
Just right.
And single stage both is anyway not a discussion in my points. I never did a single stage both sides similarly, never did so far. I dared to with UKAs and it did good. Also with patellofemoral replacement did good, but osteotomy I never dared to. I don't know if you did.
Not for slope, but
not for slope.
Coronal alignment, yeah.
But if you did, then we say slope is the best outcome, the fastest outcome. So one could dare to. Maybe I do one time if I'm as daring as you are in France or in England, but I didn't so far. So I would first of all go for the right side, and if he can if he's coping good with the left side, I would not touch it right now.
Okay. I will switch this one to the tough question. So I want you to spend some minutes on that, which what we call the consensus algorithm of slope for the four of us. How do you define a threshold on a patient with a primary ACL? We don't talk about meniscus. He had the substantial drawer, let's say 1 centimeter. What will be your threshold to discuss about slope osteotomy in a primary setting, Jörg? In terms of measures of the slope, what we can call a triple diamond black slope.
Primary setting, I would go high. I would go higher than 15, let it be 16 or 17 in that kind of values.
Rag?
Yeah, I'm with Jörg. I think a lot of the papers suggest above 15, but I've not done it yet.
Yeah, I would say like 16, a little bit depending on the activity and the age of the patient on top of that. So if it's like 40, 48 years, typical patient now in Munich for skiing, yeah, then even with a 16 or 17, maybe I wouldn't do like a slope correction on this girl.
First revision, Mirko. Where your threshold is going. First ACL revision. He already failed an ACL.
Yeah. So definitely depending on the activity and this age. If he is high active, playing soccer, handball, I would start with 13.
13.
Yeah.
Right.
Yeah. So similarly, patient profile. If they're doing cutting sports, for me it would be a 12-degree. Cutoff for me is a 12-degree slope.
Same for me. The 12, and depending on his activity level.
Second revision. We don't discuss anymore. So what would be your minimum to be corrected then? You have a patient with a third ACL failure. You have to have the fourth graft. Okay? The slope is 10. PPTA 80. Would you try to do a 5-degree correction to return back to a, let's say, standard slope of 85 ppta, 5-degree slope? Or it's not enough to be promoted?
Never done with a slope of 10. I've seen some with a fourth revision, but they were having severe slope values.
Yeah, I mean, if you look at some of the papers that were done by Imhoff and his group, they were still doing them in slopes which are a lot less and correcting them to 5. I've never done it. My cutoff is still 12, but we don't know the answer. We're waiting for the evidence.
I don't trust in the problem of 10 degrees of slope. So we do a lot of research about MCL and all the other periphery problems. And I deeply trust in if a patient had like 4 ACL or the 3rd or 4th ACL re-rupture, then I would definitely expect something problem in the periphery of the periphery ligaments.
Deep
I think
MCL, lateral.
Deep MCL, AML, like an overseen MCL, a slight instability. I think it's a higher chance to find a problem over there and not in a 10-degree slope.
This one is tough too for you, Jörg. What is your threshold to do a biplanar correction in terms of varus and valgus when you have to do a slope? So you have a patient with a 15-degree slope. When are you starting to think about correcting the coronal alignment at the same time? Because we know that 5 degrees of valgus and 5 degrees of varus are also detrimental factors of failure of ACL already. So would you measure the coronal alignment and say, okay, you have 15 and 5, we correct both, and we discuss how after?
Hard question, and I agree with you in the values about the axis of 5 degrees.
5 degrees.
We have a real severe influence on the ligament, proven for varus, no literature on valgus. We were talking with Mirko today about the subject that it's quite hard to correct coronal and sagittal alignment combined. Some do, but in my hands, it's very hard. To do an anterior closing wedge, it's nearly impossible to do a coronal alignment correction. In my hands, not. You can. It always tends to be a little bit more varus afterwards, but it's hard to do a correction in that way. If you come with a medial open wedge osteotomy, that's what I would do. If he has a frontal axis malalignment, I would do a medial open wedge, a valgization, and then you could go for a correction of the slope about 6 degrees, 7 degrees. If you're really good, you have to totally disrupt the hinge. You have to put more place in your tuberosity osteotomy, and then you maybe get it 7 degrees correction. So if he's coming with a 15 slope, then you can maybe, if you're good, bring him down to 8. And the coronal alignment you can correct, of course, at your target. So it's hard to do it in both together. Even PSI can help us more in the valgus component, because then you have a closed wedge. I did a closed wedge, 10 degrees valgus, 10 degrees slope with a PSI from Newclip. That is possible, but with the open wedge, it's quite hard.
I will switch to the next one because we need to discuss a bit of the technique, because the 3 of us are big technicians. So I shoot a lateral X-ray that you can show. Where is your ideal starting point for the cut? Imagine that the second one would be more distal. So are you a suprapatellar, a supratubercle? Are you a retrotubercle, or are you an infratubercle surgeon? First thing to discuss quickly.
I started transtuberosical, but I left it, and I always go infra right now.
So I'm from the school of Ronald van Heerwaarden. So I take the tubercle off, but more recently I've been going supra.
Infra.
Infra for me too. So what is your landmark, Jörg? And I think it's something that is not really described. Compared to the top of the tubercle, to start shooting your key wires. For the first resection key wire, the upper one.
The proximal wire. I was afraid in the beginning that the patellar tendon could disrupt if you don't leave it enough space. Right now, what I see, if you get about 2 centimeters below the tube tip, it's enough, and I didn't see a patellar tendon rupture in that. 2 centimeters below.
Mirko?
Yeah, for me it's pretty important really the shape of the knee. So sometimes you have a very small shape, And then you need enough space in the proximal part for your plate. This is important, I think. So for the direction of the screws. So therefore, I think it's not completely easy. And another point I think it's very important is you have your tunnel. And Jörg, you always mention most of the time we do a tunnel filling together with a slope correction. And the tunnel is something which is the weak point for the tip. And if you have a very short distance to the tip, then it's very small, and then you have maybe a big tunnel on the tibia, and when the tunnel is pretty high, then there is a risk of a rupture, of a fracture. And I had one case, I had a rupture, the fracture of the tip, because it was very near to the tunnel. The tunnel was really big, and my osteotomy was too high, too proximal. Okay. And this is something I've learned in the past, that in these cases I try to be a little bit more distant.
And aren't you afraid about the shape? I can probably show an X-ray. This one, for example. Are you afraid about the shape of the tibia? So this is a case of mine, pre-op, 1 month, 3 months. Aren't you afraid about this step anterior, just behind the tibial tuberosity? So this guy got a BTB as a second revision. This way you have this weird aspect on the post-op. I did the 2 centimeter below the tip tubercle, as we always do. Are you afraid about this shape of this small step just behind of the tibia? Because it's one of now that if you look at the literature, we're going to discuss in the last 5 minutes about the literature a bit. The only thing that for me remained an issue and a question is what will happen in 3 years regarding this weird tibial proximal aspect, because we have this step just below the proximal tip fib. Are you afraid of that?
Not really, no.
Jörg, you have the most...
In closing wedge, only in the open wedge. When you have a posterior, then it can be a problem. Then you have to go transtuberosity to avoid that. Not in closing.
Okay. I want you to explain your technique, but we don't have time to go through everything. So just give me the 5 best things you need to know when you want to do an infra, a supra. I will give you mine, which is on an X-ray actually. You can show the image. Position the plate before cutting. Can you show the X-ray? So this is my first X-ray. The PowerPoint, please. This is my first X-ray before anything. I put the plate on with a perfect anterior-posterior view. I fix the screw proximally. I remove the plate. I leave the distal the drill at the distal aspect to be sure that my cut will not be impinged with those screws. And then I switch my X-ray to the lateral aspect to do my osteotomy. And I will highly suggest this plate is perfectly designed. One of the designers in the room. This plate is perfect. The only thing is it's very hard to have it perfectly matched on the frontal and lateral X-ray. So before cutting and doing crazy job with your key wires and your saw, position the plate and fix the 3 proximal screws, because you can remove everything and return back to those holes without any problem, as long as you're not trying to fix it distally and proximally, because otherwise you cannot close anymore, of course. But this is my number 1 tips and tricks. Jörg, what are yours?
So I come point 2. Important point is to set your hinge in the exact place. The hinge place is in the root of the posterior cruciate ligament, and in this place the bone is very failure forgiving. So if you take this orange line,
show the images, please.
Picture,
yeah, perfect.
And we always are putting our saw on the distal side from the wire. So this would be by far too distal. So you should go too distal. You should go. The hinge point is about 0.5 more up there, just where it's making
in the curvature.
In the curvature. There, it's metaphyseal bone. It's very good hinge, and I did not see any problems with hinge fractures if you hit this point exactly.
Rags, technique number 3 in supratubercle. Do you have 2 free top tips we need to know?
Yeah, so I think making sure that you've got a proper exposure around going deep to the medial collateral ligament around the tibialis anterior, so that you've got retractors in place. Because sometimes your saw blade is going into positions you can't fully see it. So doing a good exposure from the front, making sure that you go all the way up to the hinge point with your saw, okay? Because there is a risk of fracture. It is very forgiving in that area. But you need to be quite daring to go all the way up to your hinge point so you get an easy closure. And then after that, your biplane osteotomy is key. You need to make sure you've got enough, particularly in a revision scenario where someone may have done a BTB before, have a really good bit of tibial tubercle left behind that and protect your patellar tendon.
Mirko, we have one question for the internet. Always use a plate?
Yeah.
In infratuberosity, there is no option,
No,
if you want my opinion.
I think there's no option.
In
The
Supra,
plate is perfect.
the staples are enough.
2 compression staples, they keep out of your way of your ACL tunnels.
If you have this X-ray, so Jörg, we have this issue. Something wrong happened. For a reason I don't know, my resident decided to cut above the key wire position. I just turned my head and in a second, it cut into pieces the proximal plateau. If the real thing is it's a cadaver session training for resident, don't worry. But what will you do if you have this hinge fracture, which as you said is almost impossible to obtain? What will you do?
This is, first thing is keep calm.
Breathe.
Cancel your next operation point and take your time. And then remove any kind of metal here. The K-wires need to be out, the plate needs to be out. Everything set on 0. And then you have to do a reposition like a tibial head fracture. Now it's no more a slope osteotomy, now it's a tibial head fracture. Then you make leg screws, 3 or 4 leg screws, maybe with a plate. Maybe it's even possible only with screws, maybe plate better. From anterior to posterior leg screws. And then you get a how in German say, water-resistant reposition. I don't know if this exists in English language. And you get a good reposition, and then the tibial fracture needs to heal. And then second step is you do the slope osteotomy, or if the patient a little bit loses his trust in your hospital, then you send him to some good friend to do the slope afterwards.
My question is, are you able to finish the job? You said no, and I agree with you. The only way to correct this fracture is usually to return the tibia what it was.
Exactly.
So to uncorrect.
Exactly.
So you will graft the wedge you removed, and you fix it in position where it's not corrected anymore. You don't try to force the correction in this scenario because you know that you will have a step intraarticularly.
Exactly. You have to step down to 0 again.
Okay. Post-op specificities. This one is a big fight between Rags and Mirko, let's say, because we don't have the same post-ops in infratubercle and supratubercle. So what is your classics?
Yeah, it's pretty interesting. So in the past, so I started to let them be more active. So because the patient, they give me the idea like after 3-4 days, they don't need painkillers and they feel so fine. At the beginning, I started with 6 weeks of partial weight bearings, and they went down to 3 to 4 weeks of partial weight bearing. Then I had this complication because of the fracture of the tip. And then I came back a little bit because I was a little bit afraid of maybe the tension of the patellar tendon when they're walking, and maybe they're slipping away or something like that. So now I'm between 4 and 6 weeks of partial weight bearing in the normal case. But I'm a little bit afraid of this because of this case. But I think now with the right positioning of the plate and a little bit more careful, I don't see a big problem to put weight on it after 4 weeks.
Return to sports, return to job. If there is a classic desk officer, whatever.
Pretty fast. So I think it's like a normal job, like working in the bureau and everything, driving car after 6 weeks. I don't see any problems.
Rags, what is your following?
Yeah, so I used to do retrotubercle, so we'd have to protect the tibial tuberosity, allow them to fully weight bear and full extension. But it was 6 weeks and gradual getting range of movement back. I'm far more aggressive with my supratubercle. They heal much quicker. The bone is really good, cancellous healing. And with the staples, I still do a sort of partial weight bear for about 3 to 4 weeks. But after that, get them fully weight bearing, and they return to work pretty quick.
Jörg, I saw your paper on Kesta recently. You speed up, 3 weeks, full weight bearing.
Yeah, even faster. We were together with Philip Schuster from Mark Gröning, and in my concept, they're even faster. They got 2 weeks of 20 kilo partial weight bearing and then come to full weight bearing ASAP. So most of them 4 weeks without crutches, and at the 6 weeks control, they come with a fluidly walking circle. Their gait is totally normal there.
Yeah, since I switched my technique to yours and go to the Infra 2, most of my patients are able to run at 2 months. And it blew my mind because most of the time it's the third revision, and the patient says, as you said, I feel completely confident. Can I run on it now? And I say, and you have the images here of a patient I saw this morning. You see, 3 months, completely healed, no big question. The plate will hold anyway, so nothing bad can happen, and the job is done. I mean, I'm not afraid of anything. So they can return back to complete. To finish, maybe I forgot something you want to discuss in the last 5 minutes about those techniques. Do you have something in your mind that we need to say to the people?
So maybe one topic I'm really deep in thinking about that is about the hyperextension of the patient.
Exactly.
So I think this is an absolutely open question. And what is the normal history of this patient? And do we have to be afraid of a hyperextension? And what is the threshold of a hyperextension?
Yeah.
This is even a nightmare to answer. Maybe now, maybe more complicated than just a threshold to do the osteotomy. So I think it's very interesting.
So you will say that one of the contraindications, because we didn't discuss about that, is the patient with a pre-op recurvatum of more than like 10 degrees. Because by essence, if you do a 10-degree correction slope, this recurvatum will move to 20. It's almost impossible to don't have this. Yeah. Or you can do a technique of posterior capsule shrinking or something like that, which probably will not work.
So I discussed already today with Jörg, so that's very interesting if you just think about the biomechanics of the periphery ligaments. If you do a shrinkage of the capsule, for example, then you change the situation for the periphery, because the periphery usually is only tense in full extension. And if you shrink the capsule, you don't have a tension of the collateral ligaments. So we have no conclusion about that, no data, no studies about that. But I think it's very interesting if it's really fine, really right, just to shrinkage the capsule, to bring it in a suboptimal or like an unnormal position for the periphery. Maybe they end up with a problem in the periphery ligaments, although they are in like a 10 degrees overextension than they had before.
Or maybe the quadriceps.
Sorry?
Maybe the quadriceps, because they will say that the quadriceps is set up to work with a certain distance in between the patella, the tibial tubercle, and so maybe if you create something that creates recurvatum, they lose some quadriceps. If you shrink the capsule, they don't have strength anymore to flex it. Jörg, are you doing something specific on those recurvatum patients?
We do. I do no shrinking of the posterior capsular. I think there is enough hematoma if you did osteotomy with a hinge down there in the back, in the backyard of the knee. It's enough hematoma, but I do a hard frame orthosis afterwards with giving a little bit leg of extension, like 1090 for 6 weeks, and then it slowly comes to some kind of scar tissue in the back. At least that's the idea for me. And then I do not see, like Mirko says, I do not see the problems of over or hyperextension afterwards.
I do PCL brace for all my patients. So the Armor PCL, for example, with a -10, let's say, dynamic stop. So they cannot go further. Even if they have the brace, they can walk on that. So for 6 weeks, I put them into PCL brace for this question. And I rarely see issues with recurvatum and patients complaining about that after 3 months, because before these 3 months, most of the time they still have not enough quadriceps to stop it intentionally. So they will say like twice a month or 3 times a month, I have the feeling of the knee getting in backward, which is weird. After 3 months, they don't complain about that anymore. Rags, on Supra, do you have a...
Don't really see it as a problem. I do put them in a splint, a rigid splint, just to keep them in extension. I think that hematoma you mentioned is a really important part to stop them going into excessive recurvatum. But out of the patients, I've never seen it be a problem, not symptomatic.
Nico, you have something?
Yeah, I think it's the same experience that like I haven't seen any patient who told me or who was asking me what's happening to my knee or my lower leg. Now we're performing a study around 100 cases, and I checked them before operation, during operation, after 3 months, and then most of the time we do it in 2 steps, and then after ACL reconstruction. And what I see now in the preliminary results that between the removal of the plate, so before the revision ACL, some of them, they have still an overextension, but then after the ACL, and they always tell them,
don't be afraid.
Yeah, that's it. And don't be like, usually I have to tell them, go in full extension, and you have to work hard, pretty hard to get in full extension. Then these patients, I say, take it easy.
But
don't go in overextension.
In your intraoperative visualization, you see that you create substantial recurvatum or not?
Yeah.
Because my resident always say, is this normal that the leg is in? When they hold the leg, when I'm putting the plate, the compressive screw of the plate, they're like,
sure,
it's a lot. I say, no, don't be afraid. And as soon as you remove everything, you undrape the patient, there is no difference. Yeah. But when you reduce the osteotomy, my resident always like, oh, you cannot fix it like that. I say, yeah, it looks strange for 15 minutes. So 2 last slides and 2 last questions. Do you have a paper that change your vision in osteotomy that you can recommend to our audience?
Yeah, of course, it's like the Pincheski paper and the Andreas Weiler paper about the PCL and the benefits. It's amazing if you see like the results of a PCL is 100% lying on the slope. So if you are a perfect PCL surgeon, but you have a bad slope, you end up with a bad result. So for me, it was maybe more important. I see my result is just relying on the slope in PCL. And this was the beginning for me just to think about ligament surgery and slope correction.
Rags?
Yeah, so there's a couple of papers for me and a book. So the Salmon Pincheski paper, I think that was game-changing for our understanding of revision rates. And in terms of the techniques and things, the David DeJour paper, looking at his slope corrections, which he did years ago, and he followed up, I thought that was a really nice paper. But I think anyone who's starting out with osteotomies, considering slope, the doyens of osteotomy with Ronald van Heerwaard and Alex Staubli, the Osteotomies Around the Knee AO book is an absolute Bible when it comes to this kind of work. So for those of you listening, I think that's a good go-to book.
Jörg?
Yeah, for me, the Australian paper about the threshold values is one point, and then as I changed my mind to this infratuberosity technique. There was the paper from Wolf Peterson about first describing this infratuberosity technique. These are two highlights in osteotomies depending on sagittal plane, I think.
Okay. I would recommend the paper of Jörg published in Kesta 1 month ago, which blew my mind because, I mean, I'm doing a lot of those infratubercle, but when you look at the numbers, you see that they do 200 in 3 years. You can always discuss, and the results in terms of healing and so on are very crazy. I will also recommend the paper of the Lyon team, the David DeJour team, on the tibial translation and slope, which is really amazing. They really define the effect of the slope, not anymore on the ACL rupture and so on, but the impact on the anterior tibial translation in weight-bearing scenarios, which is really, for me, an important point. And sometimes I can put the indication of the slope change in first revision based on the amount of tibial translation, because for me, on those post-meniscectomy patients, for example, if you don't do something on bones, it would be non-forgiving for the arthritis phenomenon in a few years. Last slide. Free message for our trainees. Do you have something to say for the people that want to learn slope osteotomy?
Just the slope, or just everything in the
everything. Wow. A message, everything, a bottle in the water. Like I put something that will stay forever.
One of the most important messages, like if you think about it, do it. So this is one of the most important part in OR. If you think about maybe I should check it, do it.
Rags?
Go and see somebody. Go and see somebody who does a lot of these slopes. Get in the OR. Watching videos is great, YouTube and things, but actually go and visit somebody who does a lot of these. Gentlemen like yourselves, go and see, get the feel of osteotomy, particularly slope change, and then try and do it.
Jörg?
I think never think that you're invincible. like that's important for surgeons. When you start, you're always a victim. You have much failure. You're getting yelled at every day, and then it gets better and better. You're getting faster. Results are getting better, and then comes the point when you think you're invincible, and just a week afterwards, you get a real severe complication. It always happened to me. When you're flying too high, you're falling really deep. So really, don't lose the contact to the bottom.
True story. I will say for an experience that happened to me this week, just as you said, I tried to do a revision ACL, meniscus allograft, slope change, and a contralateral root repair in the same stage. It was a tough case. My staff still remember. But it ends up perfectly, but it took me 2 hours, which is rare in this kind of scenario. One last message. Thank you for being with us, and thank you for the three guys that entertained me with the answer to my questions. I hope you liked the format. It was pretty unusual to try to do that, and thank you PCO, Etienne Cavagnac, Nicolas Reyna, for allowing me to do a pure interview style. I hope everybody liked it. We want to have your feedback on that because it's a kind of format I want to see and watch, but sometimes I'm the only one. So, and maybe you enjoyed it, and I hope everybody in the internet enjoyed it, and you find the answer to questions that are really hard to find when you just look to PowerPoints and papers. So I tried to ask the question that people don't focus too much on that. Again, thank you to everybody. Thank you for the my free speakers, and hopefully we will have some question that we can answer on internet after that. The last question we need to understand, because it's the last internet question, what about arthrogenic muscle inhibition after slope and ACL? I will tell you something. I've done, I think, 75 slope change osteotomy in my life. I see 0 arthrogenic muscle inhibition in this scenario, compared to a classic 30%, 30% in primary ACLs. What do you think?
The same. I agree.
Because the thing is we give them a small hyperextension at the beginning. So maybe it's the reason why we don't have this lack of flexion and this VMO issues and this hamstring issues that we see in primaries, because they have the ability to extend a little bit more at time 0 because of the slope osteotomy. This is my vision. What do you think, Jörg?
I've never seen it in the osteotomy. I've seen it once in the ACL. And we have a publication with German Knee Society now. We are a little bit trying to take the shoulder pacemaker from Moroda to the knee. We call it the knee pacemaker. And we've been trying the first patients in Italy with Florian Perwanger and with Christian Schöpp in Duisburg, doing a knee pacemaker for arthrogenic muscle inhibition. That could be a point of hope for this severe pathology.
Rags?
Yeah, I don't think it's a problem, to be honest. I agree with you. The way that we've got the recurvatum and the muscle inhibition doesn't normally play a role. So I think it's a rare problem to have.
So thank you for everybody. We are 15 minutes late. Once again, thank you for being with us on the slope tonight. And hopefully we'll have a next session on the same kind of webinars sooner or later with PCO. Remember to join the Congress in May in Toulouse. And once again, thank you for Newclip and PCO for organizing this meeting with us. See you.